Hello, everyone, and welcome to MedSurge 4. This is Chapter 18, Caring for Clients with Cancer. Make sure that you go into your Prep U and complete your Chapter 18 Prep U assignment. So here are the learning objectives for Chapter 18. And you can also find these objectives in the escape room that you have on Blackboard. So you can go in and do that escape room, and this basically covers the learning objectives. Also know that there is a chapter in your ATI book that covers all of the cancer disorders that we have talked about in your previous MedSurge courses. I've actually summarized that into a PowerPoint, so you can review that for NCLEX. I'm not going to test you on that for your oncology test. However, it is a good review, especially with your NCLEX coming up. So take a few minutes and review that PowerPoint. So now let's talk about the pathophysiology of cancer and exactly what is cancer. On this slide, you will see a link that you can access, and it will give you some more detail on the pathophysiology of cancer. But know that cancer is when the body's own cells replicate unchecked. You have normal cells that have a regulatory mechanism, and these tell the cells when to stop. However, cancer cells do not have this regulatory mechanism. Cancer is also classified by growth as well as tissue type. So here are some examples. Carcinoma is related to your epithelial cells. Lymphomas are organs that fight infection. Leukemias affect organs that form blood. Your sarcomas affect the connective tissue, bones, or muscles. Now, you can have a tumor that can be either benign or malignant. So, this again, we have well differentiated cells, and they look normal, and they tend to grow and spread slow. While your poorly differentiated or undifferentiated cancer cells are the ones that spread and grow quickly. Differentiated is used in tumor grading system, and they're different for each type of cancer, and we'll talk about the grading system later. So let's look at the difference between a benign tumor and a malignant tumor. So your benign tumors are non-invasive. They tend to grow large, but they have a very slow growth rate. They usually do not cause death unless it grows so large that it begins to impair the function of a vital organ. So we tend to think of benign tumors as harmless, unless, like I said, it starts to impede on an adjacent organ. Now you have malignant tumors, and these are your invasive tumors. They have uncontrolled growth. So these are your undifferentiated cells. These are the cells that grow unchecked. They cause alteration in the cell membranes. Fluid movement in and out of the cell is impaired. And then they also produce tumor specific antigens, which you will see in some specific blood tests that they do for tumor detection. So here, once again, there's a link on this PowerPoint, and it is the difference between a cancer and a tumor. So be sure to click on this link and look at that YouTube video. So know that whenever a client hears the term metastasis, that it is very discouraging to the client. Now, metastasis is the development of secondary tumor from a primary tumor, and it can spread through lymph nodes and through blood vessels. So when you think of metastasis, that's how it's going to be spread from lymph vessels adjacent to lymphatic vessels, transport from blood to lymph system, and then diffusion within the body cavity. That is how metastasis occurs. Um, Select the link provided that talks about tissue invasion and metastasis. So the etiology of cancer is it is the second leading cause of death in the United States. 1 in 2 men and 1 in 3 women develop cancer at some point. The most common cancer is lung cancer. With men, prostate, lung, and colon cancer affect them the most. With women, breast, lung, and colon cancer affect them the most. Know that damage to the DNA has occurred. The cell in the gene has become mutated or damaged, and that is what forms the cancer. Now, know that you have inherited gene mutations, and that can occur with your breast or ovarian cancers. That's where you see that most likely. So, let's talk about contributing factors. Contributing factors are things such as chemical agents, and this can be in the form of tobacco, nicotine, exposure to asbestos, pesticides, and formaldehydes. And when you have those type of chemical exposures, you see that affect the liver, the lungs, and the kidneys, and that's due to the biotransformation that occur in those organs. Next, you have environmental factors that can contribute to cancer, and that can be your sunlight, and you'll see that in the form of skin cancer, radiation exposure, pollutants, electromagnetic fields, and nuclear power plants. Our diet. So, our diets are high in fat, nitrates, alcohol, and obesity, as we know, is a problem. So, our diet really has an impact on development of cancer. So, that's why we need a diet that's high in those antioxidants, a diet that's high in those fruits and berries and low fat, because we want to reduce those risk factors for developing cancer. Now, there's also some viruses and bacteria that can cause cancer, such as your H. pylori or your human papilloma virus. The HPV virus can cause cancer as well. So, other contributing factors could be medications, such as medications for the immune system or hormone replacement therapies. These medications can contribute to cancer. You also may have an immune system deficiency, such as an autoimmune disorder. And some autoimmune disorders, as we know, the DNA is already mutated or it's damaged, and that can lead to the contributing factors for the development of cancer. So, now let's talk about complications and emergencies that can occur with the diagnosis of cancer or during cancer treatments. Let's start off with complications. Nutrition is a complication, and that can be the result of therapies, and it can be in the form of lack of appetite, nausea, vomiting, and even effort. The patient may expend a lot of calories more than they're taking in, and it requires a lot of effort to eat, so you may have malnutrition occur because of that. You can also have some gastric complications such as constipation, gastric, gastric stasis, intestinal obstructions. We also have paraneoplastic syndrome. And with the paraneoplastic syndrome, that is the result of the T cells in the body begin to attack normal cells rather than the cancerous ones. And this leads to neuro changes such as difficulty with movement, sensation, and even mental status changes. So, with our emergencies, we have SIADH, which we remember is the syndrome of inappropriate antidiuretic hormone. We also have hypercalcemia, superior vena cava syndrome, which is when an obstruction of venous return and engorgement of the vessels from the head and the upper body, and that can cause compression on that vein and impairs blood flow. We also have hematological disorders such as anemia and DIC. And DIC is a loss of uroclotting factors. These are just some complications and emergencies that can occur with the diagnosis of cancer or during treatment. So make sure that you go back and review those signs and symptoms and treatments for your SIADH, your hypercalcemia, your hematological disorders such as anemia, and your DIC. So, the American Cancer Society uses caution to help them distinguish signs and symptoms of cancer. So, let's start with C. And C is changes in bowel and bladder habits. A is an unhealing sore. U is unusual bleeding. T is thickening lump. I is for indigestion. O is for obvious changes in signs of a wart or mole. And N is a nagging cough. Some other signs and symptoms to consider are headaches, weight loss, chronic pain, persistent fatigue, low grade fever, and infections. In your book in chapter 18, there is a table listed with the title Possible Warning Signs of Specific Types of Cancer. Please review that table and be familiar with those specific signs. So, cancer prevention is so important, and let's start with educational awareness. So, we need to teach warning signs of cancer, risk factors or contributing factors, and modifications that can be done in order to decrease those risk factors. Screenings such as mammogram, prostate exams, and colonoscopies should be discussed with the client, as well as the importance of a yearly physical, and know that it also plays a vital role in detection and prevention of cancer. We need to also emphasize and teach self exams such as breast, skin, and testicular exams, as well as how to avoid those risk factors such as adding antioxidants to our diet and applying sunscreen and getting proper vaccines such as the HPV vaccine, which prevents cervical cancer. So, prevention plays a key role in cancer prevention. So, screenings, when we talk about mammogram, mammography needs to be done on a yearly basis or up to the discretion of the physician and whatever discussion they have with the client as far as history goes as to how often they're going to do a mammogram. A monthly self exam should be done, and that's done 2 to 3 days following the period. If it's irregular or during menopause, it should be done the same time every month, preferably while showering. Breast exam, use the palm of the hands in a patting motion, and finger pads, the middle 3 fingers. You're going to use those fingers for your palpation. You stand in front of the mirror and do a check of the size, contour, dimpling, any discharge that may be noted. With a pap smear, you're having that done by the physician, nurse practitioner, or PA, and that's for the detection of cervical cancer. For the testicular exam, the testicles should be gently rolled to feel for any abnormalities that may occur there. A colonoscopy, such as a flex sigmoid, can be done every 5 years, starting at age 50. And then you have a yearly occult blood test. So whenever you go in for your yearly physical, they may give you an occult blood card to take home that you're going to get a stool sample and either return that to the doctor's office once you've completed that. So the occult blood is done yearly. The flex sig is done every 5 years, but it does depend on polyps and the discussion with the physician and their findings as to the more frequently or less frequently you will need it. But on average, it's 5 years. So there is an array of diagnostic methods that we use to obtain a diagnosis of cancer. Let's start with a client's history as well as physical exam. During the history, you're going to see if there's any family history of cancer and what type of cancer. And during physical exam, you're going to look for any abnormalities. As far as our lab test, you're going to do those specific organ function tests: renal, pancreas, thyroid, liver. You're going to look at those tumor markers, proteins, those specific antigens, hormones, genes, or even enzymes released by the cancer cells. Looking at a CBC, we're going to be looking at that H&H and that RBC. Also going to look at the number of platelets as well, because we're going to determine if the patient's at risk for bleeding, because some cancers affect the bone marrow, as we've talked about, so they may be at risk for bleeding. Going to do a variety of x-rays, including CT scans. We can inject iodine or barium. We can do tumor density test as well to determine location and size of the tumor. So other diagnostics could be MRI, PET scans, ultrasounds, fluoroscopies, biopsies, and biopsies can be shaved skin, shedded cells. We can also do tissue biopsy of sentinel lymph nodes. You can do a superficial biopsy, like an excision of a lesion that you're looking at. You can just take a small shaving of that. We can look at secretion such as sputum and urine as well. We look at all these under a microscope because you're looking for those abnormal cells. Endoscopies include a gastrostomy as well as a bronchoscopy and a colonoscopy. So we can obtain samples during those procedures to look at under the microscope as well to help us with the confirmation of cancer. So we could talk about grading cancer or staging cancer. So first let's talk about staging. So staging of cancer, stage 0. This is the stage that describes cancer in situ, which means in place. Stage 0 cancers are still located in the place they started and have not spread to nearby tissues. This stage of cancer is often curable, usually by removing the entire tumor with surgery. Stage 1. This stage is usually a small cancer or tumor that has not grown deeply into the tissue. It also has not spread to the lymph nodes or other parts of the body. It is often called early stage cancer. Stage 2 and Stage 3. In general, these two stages indicate larger cancers or tumors that have grown more deeply into the nearby tissue. They may have spread to the lymph nodes but not to other parts of the body. Then you have Stage 4, and this means that the cancer has spread to other organs or parts of the body. It may also be called advanced or metastatic cancer. Now, as far as our grading system, that differs depending on the type of cancer. In general, tumors are graded 1, 2, 3, or 4, depending on the amount of abnormality. In grade 1 tumors, the tumor cells and the organization of the tumor tissue appear close to normal. These tumors tend to grow and spread slowly. In contrast, the cells and tissues of grade 3 and 4 tumors do not look like normal cells and tissue. Grade 3 and grade 4 tumors tend to grow rapidly and spread faster than tumors of a lower grade. So now let's move on to treatment. Surgery is the primary method of diagnosing and staging a cancer. Tumor excision, which is a superficial excision for biopsy, can be done. You can also do local removal or wide radical removal of a tumor. Debulking or cryoreductive surgery is just that. It is the reduction of the tumor in size because the tumor cannot be removed. Your salvage surgery is the result of local recurrence of a cancer in that area. For example, they may do a lumpectomy or a mastectomy as a result of that reoccurrence of that cancer in that one particular area. You can also do what is called prophylactic or preventative surgery, and this is when you have a family history or genetic predisposition for for cancer, such as BRCA1. The patient may be positive for that BRCA1 gene or that BRCA2 gene, and that sets them up to be positive for cancer in the future. So rather than waiting for that to happen, the person may go ahead and have that bilateral mastectomy done as a prophylactic or preventative measure to prevent that cancer. So some treatments are not always preventative or will get rid of the cancer per se. You may have to do some palliative measures. Now, when we talk about palliative measures, that's to help relieve uncomfortable symptoms such as pain or pressure. You can do a palliative surgery with that debulking or that cryoreduction just to reduce that tumor size to keep it from pressing up against other organs and causing that discomfort. You can do like a paracentesis or a thoracentesis, so the patient has a lot of excess fluid in their peritoneal area, and that's giving them difficulty breathing or giving them some pain. So you may want to go in and remove that fluid, knowing that you're not going to get rid of the cancer, but you are going to make them more comfortable. This is a palliative treatment. Now, reconstructive or plastic surgeries correct any deficits that occur as a result of the cancer or the cancer treatments. You can also do what's called a Mons surgery, which is shaving off layers of skin. That Mons surgery you see lots of times with your skin cancers, that's done. And they'll do a chemosurgery, which can be a topical chemical application to the skin to get rid of those cancer cells there as well. Cryosurgery and electrosurgery and even laser surgeries can be done as preventative, as full treatment of the cancer, or as palliative as well. So know that prior to any type of surgery that you're going to look at any bleeding times, clotting factors, what's the patient's platelet count, are they at risk for bleeding when they come back from surgery. So you want to make sure that you are doing a good pre-surgical assessment before you send that patient to surgery. And know if you see some abnormalities in the lab work prior to any procedure, whether it's surgery or implantation of a port, that you want to notify the physician so that corrective measures can be taken to prevent any potential harm coming to the client. So, in addition to surgery, you can have radiation treatment. Now, radiation treatment, that's when cells are destroyed by breaking down strands of DNA molecules, and that prevents the growth and division of those cancer cells. You can have external radiation or internal radiation. With your external radiation, that's targeted to specific tumors and lymph nodes. You may see a client have X marks the spot areas on their chest or on their abdomen, and that's a tumor specific area where that X-ray is going to be targeted to attack the cancer cells in that area. Now, with your internal radiation, your brachytherapy, that can be interstitial implants, it can be intracavity implants. It can also be given in the form of, say, iodine, and that can be administered orally, IV, or even implanted into the body cavity. So know that if your client is receiving any type of radiation treatment, you need to increase their fluid intake. Also note that if the client is experiencing neutropenia as a result of their cancer treatment, especially their radiation treatment, that we need to give them, lots of fluid, especially bottled water, because we want to prevent any type of foodborne illnesses. So make sure you increase their hydration, especially PO hydration, during radiation treatment. There is some significant side effects associated with radiation: alopecia, erythema, discrimination, stomatitis, xerostomia, anorexia, nausea, cystitis, pneumonitis, and fatigue. So your client may experience some of these side effects as a result of their radiation treatment. Also know that you may have a depression of bone marrow, which is your myosuppression. Your client can also develop leukopenia. As you remember, that's your decreased white cell count. Thrombocytopenia, which is your decreased platelet count as well. So they can have a tendency to develop some of these disorders during their radiation treatment. Fibrosis may also occur. Lots of times you may see this in your small intestine, lung, bladder, cataracts may form, or even new cancers may develop as a result of your radiation treatment. So make sure that you are following the facility guidelines to practice radiation safety for your client who is receiving radiation treatment. Make sure that you are limiting your length of exposure to the client. Make sure that you are clustering your activities so that you don't stay in the room for any length of period with the client. All of the patients should have a private room. Maintain a safe distance when in the room. If you don't have to be up close to the patient, don't. Make sure that you're using the proper shielding to protect yourself, such as a lead lined apron or face shields, proper gloves. Make sure that you're using the proper lead equipment to protect yourselves. Contaminated articles such as linens and gloves need to be disposed of properly. Make sure that you're getting rid of that properly and per facility protocol for that. If your client is receiving any type of radiation, whether it's oral or intracavity, however it's being administered, make sure that you are flushing that toilet at least twice to avoid any exposures to other people who may come into the room, because a lot of that radiation is expelled with urine and feces. So you make sure that you are flushing that toilet a couple of times to make sure that it dissipates from the room. So now we're going to move on to chemotherapy, and these are anti-neoplastic agents, and they interfere with cell function. So they actually get into that DNA and they interfere with that replication of the cancer cells. We give chemotherapy by IV. If we do IV, we're going to use a PICC line, a Hickman catheter, or an IVAD device, which is your intravascular device. We also can give it orally. We can give IM, subcutaneously, topical, intrathecal, or intraperitoneal. These are just a variety of ways we administer those chemotherapy drugs. So just like radiation, chemotherapy also has some side effects. We have nausea, vomiting, stomatitis, alopecia, and know that alopecia occurs the eyebrows and eyelashes as well. We also have myelosuppression and fatigue. Now, with that myelosuppression, you know that there is a decrease in the erythrocytes, platelets, and leukocyte production as well. That's all part of that myelosuppression. So that sets the patient up for neutropenia. So it's not unusual to have someone who is receiving cancer treatment to develop neutropenia and have to be placed on neutropenic precautions. So we often have to do that. As far as your dietary modifications, know that if they have that stomatitis, that you may want to give those not so spicy foods, those not so hot liquids. So you want to make sure that you are giving them small, frequent meals and increasing that fluid intake. They need anywhere from 2,500 to 3,000 milliliters a day. So we need to really increase that fluid intake. Make sure that you teach the client to report any excessive weight loss, any change in their level of consciousness, or if they notice any paresthesia. Have them self-report any of those findings, because that can be some major factors in their chemotherapy treatment, and that may justify some changes in their regimen. So there have been great strides in the treatment of cancer, and one of them being stem cell transplant. So, with stem cell transplant, you have a replacement of bone marrow. This bone marrow has been destroyed by cancer or cancer treatment itself, and it is being replaced by healthy bone marrow obtained by a donor. So, we have autologous treatments, which is a frozen or reinfused from the patient itself. We have allogenic, which is from a donor person. And then we have synergenic, which is identical twin or identical tissue type, that's also used. So we have these three different types of stem cell transplants. Now remember, with stem cell patients, they have no means to fight infection, so you need to monitor them closely for the development of infections or neutropenia. So we have what's called targeted therapies, and these consist of your biologic response modifiers or nonspecific biologic response modifiers, monoclonal antibodies, cancer vaccines such as your HPV, hypothermic therapy, photodynamic therapy, and gene therapy. So when we have that client going through their cancer or their cancer treatment, it needs to be individualized to that client. But in general, know that lots of clients experience fatigue. They also experience an imbalance in their nutrition, like we talked about earlier. Malnutrition is part of a complication with cancer or cancer treatment. Disturbed body image can also impact our client, as well as pain. So make sure that we are addressing all these factors. Bleeding time. Some patients, depending on their treatment or stage of cancer, may be prone to bleeding. We've already talked about that alopecia, that hair loss, whether it's, eyebrows or eyelashes, and how do we help the patient cope through those types of losses. And impaired skin integrity. So think about the client who's receiving radiation treatment and they have some burns or some mild skin redness from that radiation treatment that they're receiving. How do we go about helping that client or treating that client? What's our nursing diagnosis related to that? Think about the client who may be prone to infection. Know that they have maybe an autoimmune disorder already, and now they've developed cancer on top of that, and how that sets them up for infection. Or even how some of the treatment itself can set them up for infection. So, how are you going to protect that client? Neutropenic precautions, make sure that they're not, no live plants in the room, no raw fruits or vegetables, make sure that they're drinking bottled water to reduce any type of exposure to foodborne illnesses. So those kind of things come into play when we talk about the nursing diagnosis of a cancer patient. And grieving. So like I said earlier, metastasis is one of those terms that when a client hears, it's just so overwhelming and such a potentially devastating word that it can cause the patient to grieve. So they're already grieving that potential loss that they're going to have. And make sure that you're teaching that client as much as you can, that you're explaining to them all of their options, that you're teaching them about their diet modification, you're teaching them about the procedure that's getting ready to happen, you're teaching them about their wellness program whenever they're finished with their chemotherapy or their radiation treatment. What type of teaching does this client need during their treatment and after their treatment? So after your client has finished their treatment, whether it's surgery, radiation, chemo, whatever the plan was, and whatever the treatment they followed, they still may have a diagnosis of being a terminal cancer patient. So make sure that you carry out those tasks as gently as possible. You want to reduce any pain or discomfort if you can. Know that pain control is a top priority. Addiction is not, but pain control is. So offer them that pain medication as frequently as possible. Adequate nutrition and fluid is important, so make sure that you're offering those small, frequent meals, increasing that fluid intake as much as possible. Keep that patient warm and dry. So, whenever you're going in and you're turning your patient every 2 hours, if they're suffering from any diuresis or any incontinence, change the sheets, pads, gown, whatever you need. Keep that patient warm and dry. Control any odors that may be in the room, because some odors may be very nauseous to the client, so make sure that you're controlling any odors, and always maintain the client's dignity throughout this process. So remember, pain is very subjective, and it can indicate any existing or impending injury, and it can be associated with physical as well as emotional components. So some patients may just have that impending fear that they're going to have pain whenever you come in to turn them. So they're going to already be heightened emotionally whenever you go to do that. So you may want to offer some pain medication prior to turning the patient to help relieve some of that impending or that emotional component associated with being moved or turned, whatever, to reduce that pain or to relax that patient so that you can take care of them. Reaction to pain varies with age, gender, and culture. And remember that you can have acute pain as well as chronic pain. So, just a quick reminder of your types of pain. Remember that you have your neuropathic pain, your visceral pain, and your stomatic pain. So, it can vary just depending on the area that's affected by the cancer or the cancer treatment itself. So, just keep that in mind whenever you're treating the patient for their pain needs. So, what do we mean by palliative? Well, palliative is the reducing of the severity, denoting the alleviation of symptoms without curing the underlying disease, and this improves the quality of life. Now, palliative care can include the reduction of pain by surgery or reducing the size of the tumor. So you can't remove the tumor completely, but you can reduce the size of the tumor. And this may be done through surgery, chemotherapy, or radiation. So when we talk about palliative care, the client is not rid of the cancer. The cancer is still there, but we can alleviate some of their discomfort by reducing or removing a tumor that's in an area. And it can be done, like I said, through surgery, chemotherapy, or radiation. Now, here are some of your common medications that you may see given during cancer treatments: non-opioids, opioids, antidepressants, anticonvulsants, corticosteroids, adjunctive agents, and anesthetics. Medications can be given orally, transdermal, rectally, intravenous, epidural, intrathecal, sublingual, buccal, topical, or local. These are just your routes of administration of your um, medications. Now, sometimes there's some other interventions that we can use as far as pain control or cancer treatment, anything to make the patient feel a little bit more comfortable. We can use anesthesias, we can use blocks, we can use relaxation techniques, imagery, heat and cold therapy, massage therapy, acupuncture, hypnosis, and even peer group support. So these are just some other interventions that can be used throughout your cancer treatment.